Now this morning, it's my distinct honor to welcome our guest, the Honourable Fred Horne, who is MLA Edmonton-Rutherford and Minister of Health. Mr. Horne was elected to his second term as member of the Legislative Assembly for Edmonton-Rutherford on April 23, 2012, and on May 8, 2012, he was appointed Minister of Health. He had served as Minister of Health and Wellness since October 2011. Previous appointments included serving as member of the Cabinet Policy Committee on Public Health and Safety, the Treasury Board. He was Parliamentary Assistant to the Minister of Health and Wellness previously, Parliamentary Assistant to the Minister for Seniors and Community Supports. He was Chair of the Standing Committee on Health and Deputy Chair of the Premier's Council on the Status of Persons with Disabilities. Prior to his election to the Legislative Assembly, Mr. Horne worked as a health policy consultant for 25 years. He has led many initiatives to improve access and quality in Canadian public health care, and has worked extensively with organizations such as the Conference Board of Canada, the Alberta Government, and the Mayo Clinic. Mr. Horne holds a Master of Business Administration degree from the Royal Roads University and postgraduate certification in dispute resolution from York University. He is an avid volunteer. He has served on numerous boards, including the Alberta Mental Health Board, the Athabasca University, the Mediation and Restorative Justice Centre of Edmonton, and the Canadian Student Debating Federation. Mr. Horne is a former debater and coached Team Canada at the World Schools Debating Championships. For his continued contributions to the development of debate and speech programs, Mr. Horne received the Queen Elizabeth II Golden Jubilee Medal in 2002. Mr. Horne and his wife Jennifer moved to Edmonton in 1992. Please welcome the Honourable Fred Horne.
Thank you very much for the kind introduction, and good morning, and thank you for the invitation and the privilege to join you at Medical Grand Rounds. I know we've been trying to organize this day for some time now, and unfortunately I wasn't able to get here sooner than today, but I'm particularly pleased to be here because I know that this room and the telehealth sites that we're broadcasting to today include certainly medical residents, but they also include students in many other disciplines, including nursing and pharmacy and others. And I'm pleased about that, because what I'm going to talk today about is largely the team, your team, the teams that you are building across the province to deliver healthcare to Albertans in the future. I did want to as well take the opportunity to formally welcome the new Dean of Medicine, Dr. Douglas Miller. I'm not sure if he's been able to join us yet this morning. I understand he may be stopping by, but it's the first opportunity I've had on behalf of government to welcome him in a public forum, and also to welcome someone I have met with several times now, Dr. Lee Green, the new Chair of Family Medicine here at the university. I think as members of the university community, and certainly as Albertans, we're going to be extremely well served and well led by both gentlemen in the very, very important leadership roles that they've undertaken. I would also be remiss if I did not make a couple of remarks as well regarding the sad passing of Premier Lougheed last night. You know, I think wherever you go in Alberta, you can look to you can look to our public institutions, you can look to our strong economy, and particularly the development of the energy sector in this province. And most importantly, you can look to the quality of life that all of us enjoy today as Albertans, and you can attribute that success to Premier Lougheed, and in particular the leadership that he provided between 1971 and 1985. And when I think of healthcare alone, I think of this institution. I think of things like the Alberta Heritage Foundation for Medical Research. I think of the hospitals and the health facilities that we can find in rural communities across the province. And I realize that this was someone who was truly thinking far ahead of his time, thinking far ahead of the next budget cycle, which is 3 years in government, thinking certainly far, far ahead of the political cycle, which is typically 4 years in Alberta, and really thinking about Alberta's future, the quality of life for our people, and then today, you know, a theme we are increasingly concerned with as your government today under Premier Redford, this province's place in Canada and this province's place in the world. And the stature that we enjoy today is largely a result of those relationships and those foundations and the strength and determination that Premier Lougheed showed to tell the rest of Canada that Alberta has a role to play in Confederation, a leading role. And you know, there's no better example of where to find that than in the field of healthcare. So it is my privilege to serve as Minister of Health, and as you heard in the introduction, I do have a bit of a background in this area when it comes to healthcare policy. I actually started my career as a health planner in the early 1980s in Ontario, where I'm originally from. And I started out working in small communities with something that were called district health councils. They were local planning bodies for healthcare in those days, and it was very interesting because we were introducing some new concepts in those days that probably most of you would take for granted. We had come from a tradition like Alberta where small community hospitals with their own boards strove to get every possible service they could for their own community. And we had hospitals 10 miles down the road from each other in Ontario that were competing to get MRI machines and specialty renal programs and you name it. The focus of the healthcare system was the institution. And the next focus after that was the money. It was not a focus necessarily on coordinated services, looking at the whole needs of patients and families and communities. Certainly not a lot of talk about the role of the healthcare system in improving the health status of our population over time. Really, most of the focus was on the bricks and mortar, the money to support it, and of course the providers to deliver the care. So, you know, in those days, some of the stuff that I worked on that people considered controversial and divisive were things like simple questions like regional hospital roles. And so we were actually, the beginnings of the discussion were about how could hospitals share resources in order to provide regional specialty programs rather than each department within each hospital trying to do all of that on their own. And so it led to some interesting experiences for me when you look beyond the acute care system. I did some work in long-term care, did a lot of work in mental health, and of course nobody in those days was thinking about the fact that 1 in 5 of us in Canada would experience a mental illness in our lifetime, or the fact that a very, very high proportion of visits to general practitioners, I'm told it's around 40% now in Alberta, are for a mental health related issue. So we've come a long way, and one of the reasons, just to finish up with Premier Lougheed, one of the reasons I chose to come to Alberta, and if for those of you who are from somewhere else, you may have had the same notion as me, is that it was very clear to me that things were possible here that weren't possible elsewhere in the country. Yeah, partly because of the financial resources that we're blessed to have, but also partly because we had leaders in healthcare who were willing to take risks, who were willing to think differently, who were talking about how the healthcare system proper, namely acute care, is actually inextricably linked to things like our ability to provide housing and income support, to pay attention to public health, to take wellness seriously as part of our role. And so that is a lot of what drove me to come here. It was far beyond the time when Premier Lougheed left office, but I think that tradition and that memory is very much alive, and it's something that I've reflected on a lot about since I've had the privilege of becoming minister. So today, so enough about me. Today I want to spend some time talking to you about not just new programs and services in the healthcare system. I want to spend some concentrated time talking with you about some of the transformations that we as a government feel need to occur. These are things I talk about outside Alberta as well, and for those of you who aren't aware, we actually are regarded as a thought leader, so to speak, across the country. Mostly people come at it from the sustainability perspective. They're thinking about financial resources that are devoted to healthcare. So in Alberta, we spend roughly $17 billion a year on health, and that's including the seniors portfolio. That's about 41% of the provincial budget. In Ontario and Quebec, they are getting perilously close to 50% of provincial spending on health. And you know, that's not for a minute to suggest that we don't need robust financial resources to support our healthcare system. We do, and you know as well as I do what some of those drivers are. The demographic shift in our society, the aging population, the dramatic rise in the incidence of chronic disease, the rapid availability and introduction of new technology. There are many other factors that drive healthcare spending. But I guess one of the reasons this discussion is so important is because the debate now has been, the debate today in my view is not about how much we are spending on healthcare at all. The debate is how well are we spending that money and exactly what outcomes are we achieving for an investment on this scale. And I can tell you from the point of view, I think, of the public, or certainly within the political process for decision makers, for people like me who are involved, I am very, very concerned about the day when any province in this country hits 50%, because that will mean then that healthcare will become an opportunity cost for other important public policy priorities that we have. And if we think only about the social determinants of health as an illustration of that, those areas could include education, they could include advanced education, they could include the environment. So we don't want to see a day where healthcare spending hits 50%, because it will mean that the choices that we are able to make about other areas that support improving the health of our population over time are that much more difficult to make. So just ask you to perhaps think about that, and in the Q&A maybe I'd be interested in your reflection on that as well. So I want to spend the balance of the time talking about primary health care, and as I said, the transformation, as opposed to just program changes or tinkering. This really is about transformation. So I want to tell you what we hope to achieve in the next few years with your support. We're going to be building on an excellent legacy in Alberta. We will be working with some of the most outstanding leaders in the country, in particular within the primary health care community. But I think we have to start back with the basics. What is primary health care? And many people will have different definitions. Albertans have traditionally had to take their often confusing journey to navigate the health system up on their own, to be their own navigator. Primary health care to me is really about the system reaching out to Albertans at the first point of contact and creating a home in the healthcare system, if you will. Now, many of you will have heard about the medical home model that's out there and has been talked about by the medical profession, and that's certainly been very influential in our thinking. You will also have heard about you know, the notions around attachment of patients to healthcare teams, enrollment. There are many theoretical contexts from which to view this. But I think the bottom line for me is that if we want to have a reasonable hope of dealing with the rise in chronic disease, of improving the health of our population over time, and this is the first generation of Canadian children to have a lower life expectancy than the generation that preceded them, then I think it behooves us to really think about what that home should constitute and how we're going to build not just the programs and services that we want people to have access to, but how are we going to build the relationship with citizens and families and communities between themselves and healthcare providers that are looking after their area. So it involves thinking differently. It's about fully utilizing the skills of all health professionals from all disciplines. It's about recognizing that individuals have unique needs and communities have unique needs. And it's about acknowledging that health is more than just health care. We must link the other supports, as I've said earlier, in our communities to services we provide to patients and their families. And I'm going to talk a bit about addictions and mental health as an example of that later on. It's also about focusing on patients and family as the core team members in a healthcare team. So, you know, we pay, and particularly as politicians, we pay a lot of credence to the language around a patient-focused system, for example. But how many times, and I ask this question of myself every day, how many times do I not only acknowledge but talk in a meaningful way about the role of the patient and the patient's family or other people supporting that patient as a member of the team? So again, challenge us to think about this differently. Our population, as I've said, is growing and aging. Over the next 30 years, the number of people in Alberta is expected to grow to almost 6 million. It is in considerably less time than that. By 2031, 1 in 5 Albertans will be a senior and facing the cumulative impacts of a lifetime of living. It is no surprise that more than 4 out of 5 seniors living at home suffer from a chronic condition, but chronic conditions are not unique to seniors. It was very disturbing for me to learn early on after I became minister that more than 70% of non-seniors in Alberta, that is people aged 20 to 64, have 2 or more of the 6 assessed risk factors associated with chronic disease development. So that's just the epidemiology in Alberta that we're dealing with, not to speak of magnifying that on a national scale. And a third of the people with a chronic condition actually have not 1 but 2 or more chronic conditions. And I'm starting to learn this more and more as I'm out in the community talking to patients and families. And you would know this better than I. Lots of people living with hypertension and diabetes. Lots of people living with cancer and something else. So certain specific populations have higher rates of chronic illnesses, as you know. In 2010, about 9% of Albertans lived in low-income households, and we know that people in lower income groups have worse health outcomes than the rest of us. According to the Canadian Community Health Survey of 2008, rural residents are more likely to describe themselves as heavy smokers and drinkers and as overweight. And Aboriginal peoples in our province also have a higher incidence of chronic health conditions such as diabetes, asthma, cancer, heart disease, and high blood pressure. We see that in practice, and I know from the studies that are reported on to me, it is a factor that you're seeing in practice every day. There are identifiable patient cohorts in our population that we know about where we could choose to intervene. And I think, for example, of type 2 diabetes, and I'm sure some of you are doing this work. We've known for years, because we track A1C levels and blood tests, we've known for years who the people are who are not just have diabetes today, but are at risk of developing diabetes within the next 5 years. Yet what has the government done, or what has the health system done as a whole to reform its practices and to change public policy to use that information to intervene in those situations, to reach out to those people and to pull them back from the threshold, so to speak? The very same could be said, and I know some works I've benefited from some of the work done here with respect to screening for colorectal cancer. We know that men of my age in less than top physical form, with other factors considered, are among those at a higher risk. But what have we done on a system-wide basis in order to not just identify those cohorts of patients, but to actually reach out and offer them the opportunity to avail themselves of that screening? And then once we have that information, how is our system organized in order to use the information to help coach and mentor the patient, assuming they're motivated to avoid developing colorectal cancer or some other disease? How do we support that individual over time, not in being a passive participant in prevention activities, but in actively managing that individual's own health? So to me, that is the nature of the transformation that we're engaged in healthcare. A couple of other statistics that certainly keep me awake at night. When you look at cancer, and these are recent figures, each week in Alberta, 300 citizens are diagnosed with cancer, and 115 people die from cancer each week in our province. In terms of the probabilities, at the moment we're looking at 1 in 2 Albertans developing cancer in their lifetime, and 1 in 4 Albertans dying from cancer. And if we look out to the future in terms of the prevalence of cancer in society, the rate of cancer today will grow by 67% by 2030 if we do nothing. And that's really the part that I want to spend some time talking about today. These statistics only matter if we, and I include government in this very much so, and I want you to know that, and its ministries more than just health, but these things only matter if we continue to do everything the same way that we've always done it in the future. And that leads me to talk about primary health care, which is I think the most important topic of the day. So what about primary health care? Well, we've done a lot in Alberta. We've been leaders. Since 2005, we've established more than 40 primary care networks across the province. This began by government and doctors through the Alberta Medical Association and the health regions at the time, actually talking about these sort of statistics, but more importantly, I think bringing us as a province to the realization that the future of primary health care lay not simply in recruiting more family doctors, it actually lay in health professionals working together as a coordinated team and giving them the tools and the supports to care not just for individual patients, obviously that's the way you practice, but to actually begin the task of taking care of panels of patients or subgroups of the population. I like to think of them as communities. And we have had some tremendous success in Alberta with our primary care networks. And I think for many years we were acknowledged as leaders for embarking on that journey. And so PCNs have been a big part of what we've achieved. There have also been many innovative projects across the province for delivery of primary health care outside of the PCN model. There's been a lot of research into primary health care and into things that would better support it. And I dare say there's a realization that the business of this ultimately is the business of achieving population health outcomes. To go back to what I said earlier, making sure that we're involved in an endeavor that will result in the better health status for future generations of Albertans and indeed Canadians. So we can look for, and I have many examples in front of me and I won't take time to read them all, but just for one example, the Edmonton Southside PCN has dedicated teams for geriatric care, obstetrics and mental health. We can look in the south, we can look to the Chinook Primary Care Network. They've created a weight management working group that includes weight management clinicians, mental health representatives, and Building Healthy Lifestyles, a Building Healthy Lifestyles program. Many of these programs and services are carried out by non-physicians. The physicians are there and part of the team and providing the leadership. But in many cases, particularly in the area of chronic disease management, we see the leadership of the team emerging in response to the patient need. So if there's a particular nurse practitioner or other professional that seems to have what it takes to lead a group of people who are trying to not develop type 2 diabetes and through education and support, then that's where the leadership comes from. So I think that we need to take the opportunity to celebrate what we've achieved in terms of primary health care, but I also think it's very important that we have the courage to move forward and to realize that there's more that we can do, and most importantly that we have to find those pathways together, not with a top-down approach, not with government reading a really interesting article from some journal and saying let's do that. It would actually come from where we started, an Alberta-made solution to take our primary health care system to the next level. So I want to just take a couple of minutes and talk about what some of those opportunities might be. We certainly want to build on the success of our primary care networks, and I think I do have to note that they've approached things in very different ways. We did want to make sure that there was room for local innovation and ways to customize. One thing that we have not achieved yet, which I think is important to Albertans, is some agreement on what the core services are that need to be available at the primary care level. And I want to be very honest with you. The future that I'm trying to work toward as your health minister is a future that's a long way away from sort of random access, episodic exposure to health care as we need it. I mean, we see most of that in the emergency department. The greatest, we see people obviously who are very ill and who come in and need treatment in that setting, but we also see a significant number of people who are only there because they have no other attachment to the healthcare system. They don't have a relationship with anyone. I'm going to talk about family care clinics in a minute, but you may know that one of the pilot project family care clinics is in the Edmonton north side, and we've established an FCC there that's not very far from the Royal Alexandra Emergency Department. The selection wasn't random. We know that there are a high number of patients there with addictions and mental health needs. We know that it's a part of the city where many new Albertans, new Canadians settle and do not speak English. We know a lot of other things about the population health needs in that area as a result of study. And so by establishing a family care clinic near there, we're obviously hoping that people will make their relationship to the healthcare system through the FCC, and that is working. in spades at the moment, as opposed to, you know, the episodic interaction with the emergency department simply because they don't have anywhere else to go. And those things, you know, I think sometimes, certainly people who talk to me, when you talk about perceived waste in the healthcare system, well, the first thing is, you know, it's always somebody else. It's my neighbor or my relative or, you know, someone I know of that's not using the services appropriately. And the second thing is, and I think the more important learning from it is just people not knowing where to go. And so I want to be really clear that the objective of this work is actually related to developing that attachment. You can call it enrollment. I mean, there's many forms it can take, capitation or you know, a funding model where money follows the patient has been tried in other jurisdictions. The bottom line thing I'm looking for, and I'm not particularly hung up on how we get there, is that we build that attachment between local residents and families and communities and a primary healthcare team. And that's the way that we're going to integrate the other services that I talked about. Mental health and addictions, housing support, income support programs. We haven't even begun to talk about the possibility of schools yet and the relationships that schools can have with our PCNs and our FCCs of the future to try to reach out to youth and support their improved health. There are just so many things, and you know what they are better than me, in the heading social determinants of health that we're not dealing with. And we're not dealing with them, in my opinion, because we haven't provided that forum, we haven't provided that opportunity for the relationship to develop. I can tell you that we can't afford, I think, from a quality and a funding point of view, to make the hospital the place where the relationship occurs. Obviously, it's appropriate for people, as you look at, you know, vertical, as you look at the upper levels of care, obviously that's where the emphasis needs to be. But the hospital, of course, cannot be a substitute for broad-based primary health care. We have to rely on the community providers in order to do that. So, enter family care clinics. First of all, for those of you who may be working with a PCN, the goal it's not about the model. The goal is not to substitute or replace primary care networks. As I said, they've had varying degrees of success. I would think, you know, the major failing, and a government has to take some of the responsibility for this, is that we didn't do a very good job of evaluating our success with our primary care networks. And the Auditor General pointed out that in his report, and the result is we have a great deal of variation in terms of what's available. We have extended hours access in some PCNs, but not others. We have robust chronic disease management programs and some, not others. For some people, I think the debate has been, well, who's going to be the leader of the team? Where does that leadership come from? Others have expressed concerns about the scope of practice of other professionals, and are we inappropriately expanding the scopes of practice of other professionals? I'll tell you this, the only thing that really matters to me is that all of the resources in terms of you as health professionals are brought to bear on the needs of individual patients and on our population health needs. That's number one. And number two, to me, in an ideal system, everyone would be practicing at their top of scope. That's, if you think about it, and at least from the health professionals I've talked to over the years, most people don't want to be doing only the very, very basic things they were taught in first year. They want to be using the highest knowledge and training that they've received, and they want to be putting to, most importantly, they want to be putting into practice the things they have learned through their clinical experience and their career development for the benefit of patients. Everybody wants to evolve, and everybody wants to get better, and everybody wants to be leading edge. So to me, the way that we do that when we talk about team-based care is we design a system where people have the opportunity to practice at top of scope. And I'm certainly committed to working with you to make that happen. So a little bit about what we hope to achieve. So primary care networks and family care clinics are both going to continue to play a role. I said very early on in this whole endeavor that I'm a believer that form should follow function. So for me, the place the place we don't start is you know, how much money are we going to fund for this model compared to something else. We need to have some serious discussion about the functions that we want to see delivered in our communities. So we've been working on that. We have an advisory committee that's been established that includes representation from all of the major disciplines and other stakeholders as well, non-clinical stakeholders as well. We are beginning some more detailed discussions now about what we want to see as core services within the family care clinics. These are very much designed to be neighborhood focused, whereas most of our PCNs were a resource sharing model that span a large geographical area that at least had been the focus in the past. The idea of the FCC is for a very focused model working with a small group of communities, likely in panels, in those sorts of groupings, to meet some identified needs in those areas. So there will be a role for both, because of course the smaller PCNs and the FCCs are not going to be able to arrange for all of the resources that are going to be needed. Access to after hours care or after hours consult would be an example. There are many other services, education programs that simply demand some coordination at a regional level. And I think, you know, PCNs could have a very big role in helping provide that leadership. So both will continue. But I want to talk a minute about how our system is organized globally and what some of the opportunities might be. Obviously, my theme today is, in terms of primary health care, is integration, and trying to provide structures and processes that support the better integration of your work, not only within healthcare, but expanding to other sectors. I talked about mental health and addictions. We have many other initiatives underway in government that we think, where we think the family care clinic or the PCN could be a platform. If you think about early childhood development services for a moment, and all of those programs and services that are tied up in the Ministry of Human Services, Dave Hancock's area, and the stuff that we all want to do in terms of providing wraparound services for students in schools, particularly in the addiction and mental health field. PCNs and FCCs can be a tremendous platform for that work through an affiliation with the schools that they serve. If you think of services for seniors, for example, I've been very concerned for a long time that the locus for home care seems to be not in the home as much as it is in the hospital. We do a lot of our assessment and our interaction with patients, we do it through the hospital environment. We don't do much of it in the community. There's a tremendous opportunity here to integrate home care services and access to other facility-based services for our seniors through the family care clinic. Now let's talk about linkages to higher levels in the system. We all experience, hearing from patients, frustrations about waiting times to see specialists, to access DI. What if we actually could create a system where the navigation and the coordination of care wasn't your problem in the hospital environment, in the tertiary care level? It was actually the responsibility and embraced responsibility of the people who work at the primary care level. We have good examples all over the world of specialist linkages, some of them just using the AIM principles, where blocks of time are allocated by specialists to serve a particular PCN or FCC, if that's the case. And the patients not only have the experience of getting in to see the specialist faster, the appropriate patients actually get in to see the specialist. The Edmonton North Primary Care Network is a good example, where they have an ortho screening program, and they have trained the physicians, the specialists have trained nurses and others to, in some of the assessment procedures, things I'm told like spotting a hairline fracture. And they are able to not only refer people who need to a specialist to go there, but they're taking people out of the queue. And they're taking it with the full knowledge and support and the training provided by the specialists, but they're doing it at the primary care level. And I think there are many other opportunities where we could use primary care to leverage that kind of efficiency. And the same thing is true when it comes to diagnostic imaging. So when we think about horizontal integration and primary health care, lots of opportunities, as I've described. But also when we talk about vertical integration in healthcare systems, there is great efficiency, and I would dare say it's not just about efficiency. This can be a driver of quality in the system if you're thinking about right person, right provider, right place, right time kind of concept. And we can drive that up from the primary care level. So that's some of the thinking behind what we want to achieve with FCCs. I think probably the best thing that I could do is leave more time for questions and dialogue. But I guess in closing, before we get to that, I want to thank you for the work that you're doing, not obviously in delivering such high quality care to Albertans, but my impression in talking with providers across the province is you're doing a lot of thinking. There's a lot of reflection going on right from the level of the first year student in a health discipline about what is my role and responsibility in terms of improving the healthcare system as a whole. Very rarely do I have a physician or another professional come to me these days and talk about money problems. People want us to be competitive as a jurisdiction in terms of fee-for-service and other methods of payment, and we are. And they want us to have the top research facilities in Canada, and we have those too. And they want us to have a strong international reputation. But a lot of people are thinking about the population and the health of the population today and in the future. And they're thinking about what's my role in helping ensure that the next generation of Albertans, and children in particular, have better health as opposed to health care than the people that you're seeing today. So I want to thank you for that, because I can tell you from personal experience it's hard work. It's very easy in government, and particularly in the health minister role, to run this thing as a crisis management operation. All you have to do is pick up a newspaper or listen to the radio in the morning or read the email that comes in. Sure, we get emails from people who believe the system isn't working for them. Is that the majority of people in this province? Absolutely not. And so in saying that, you know, we do what we need to do in order to manage those situations. But the real opportunity now is to do that higher level thinking and to involve all of you as health professions in that discussion, making sure your ideas are coming to the fore and that we're building on it. So I want to thank you very much for your kind attention this morning. I hope that sheds a little light on not just programs and services, but transformation that's underway. Last thought I would leave with you is we need your support. We need your active and involvement and support. As the minister, I'm trying to make sure that we're creating the appropriate stakeholder groups, tables to have discussion. I try to spend most of my time not sitting at the table, but making sure the discussion's going somewhere, that it's in line with goals. So that sort of work is important. But obviously your work as students and as teachers is important in creating this cultural change and awareness about primary health care too. So I thank you very, very much. It's a pleasure.
So I'd like to open this up for questions. Richard.
It's more of a comment than a question, I guess, but my feeling is that we need more discussion, because the lack of transparency starts at the top with Harper, and then with the provincial government, and then with all the various things. We need more discussion and less change, because every administrator seems to think that he or she needs to leave his or her mark on the system by making changes. And changes are very disruptive. They're not just disruptive for the little area that person is changing, but there's a ripple effect, and everything has to change. And it's disruptive for patients, especially because they get used to how things are done and so on. And it's disruptive for doctors because they learn how to get things done and who to talk to. And then somebody comes along and changes the system. And you know, I think there has to be more discussion and less change. Thank you.
Okay. Just, if I could, just on that point, something I'm very aware of. The day I was appointed, and the Premier said it as well, there's a tremendous amount of change fatigue in the health system in this province. And so what you will not see is you will not see our government reorganizing or restructuring or otherwise disrupting the healthcare system. And what I'm talking about is we're not going to come out with a new plan for the whole system and reorganize Alberta Health Services, or go back to health regions. In the future, any changes in form we make are going to follow a good discussion about function. So there's a lot of sensitivity to this. I think it's a balance. Not going to take people through what they've been through the last few years, absolutely. But are we going to continue to work to evolve what we have and try to make it better? And raise the bar for ourselves as a system and as professionals and as policymakers? Absolutely we are, and we're going to do it by trying to look on building on what we have for some broader goals around population health and child health, as I discussed. But I take your point, and I am very aware of it.
So there's a large and consistent body of evidence that income and wealth disparity is really an overriding determinant of health, and I think it's the case that Alberta really has one of the highest levels of wealth disparity of any Canadian province. So can you say something about how you're going to address this key health determinant, which presumably would involve working with other departments in government and policy on a much broader front than simply within Alberta Health?
Sure. Thank you for the question. Yeah, we certainly know that that income disparity is a major factor. One of the things we did early on with the Premier's leadership was we changed the whole decision-making process in the government. I think the effect of what you're talking of, the reason that it doesn't get dealt with traditionally, at least from a policy point of view, is the silo effect that we have. So we now have a decision-making system where, for example, I'm talking about early childhood development because Minister Hancock has a major mandate for that in his ministry, and you know, we're not going to make a dent in that unless we're actually developing the policy in tandem. So yeah, the health minister's job is to obviously to look at acute care and make sure that things are functioning well. But when it comes to me talking about primary health care, there's no way that I can do that without acknowledging those other factors and without working in a coordinated way with his ministry. So that's why I talked about the PCN or the FCC maybe being a portal. It will be a portal to reach out to vulnerable populations. And so the Edmonton North PCN that I talked about is an example. People vulnerable because of income, because of being new to Canada, because of addictions and mental health issues. So it's something that I think we're getting a lot better at, because when we go to make decisions, not just about the policy, but about the money, we have built into our system now ways for those checks and balances to be made. I think if I look across the country, I don't know that anybody's really got it 100% right yet. I think a driver of it is, as this gentleman said, more discussion. And you know, if you think about his point about transparency, it's actually getting out as a minister and not talking about how much money is being spent or individual programs and services. It's talking about the societal outcome that you're trying to achieve and keeping that uppermost in your mind as you know, at least in my role. So it's a good point. That's internally it works differently now. I guess the best example I could give is the Safe Communities Fund, for any of you that are aware of it. That whole Safe Communities initiative, it was coordinated between, I think, 6 ministries. So they worked together to develop the policy, but then they took the money associated with those initiatives and they put it in a separate pot. And so every time a minister wants to do something under the Safe Communities initiative, they actually have to go back and apply to use money in that segregated fund and justify it against the original objectives that were set out.
Mr. Horne, if I may, I have 2 brief questions. The first is a follow-up to a question that was posed to Mr. Stephen Lockwood on Monday. An example was given to him where closure of operating rooms led to increased wait times in the hospital, and therefore, while the OR budget was balanced, the wait times resulted in increased length of stay and an imbalanced budget on the other department. So for that, I just like your thoughts about how you see to bring those teams together to solve the global budget rather than just each individual worrying about theirs. And my second brief question, I'm sure it may be on some of our minds, if not all of us, is that with regard, I know you've expressed a firm commitment for physicians to have an agreement with government. And yet there was, prior to the election, a signed agreement in principle with the AMA. I'd like to sort of get your thoughts as to why this agreement in principle was allowed to lapse and why the negotiations are taking so long. Thank you.
Well, I'll deal with your first question first. I think the way forward is with respect to you know, resource allocation within the acute care system, if that's what you're most interested in. I think the way forward for that, and I'm not an expert on health system management, but is the strategic clinical networks. And I know I've met twice now with the leads of the strategic clinical networks, and it's not my job to tell them how to organize things. But, you know, a lot of these issues, I think, go back to difficulties around physician engagement and probably others as well under Alberta Health Services. And I usually start a speech, or I did when I was first appointed, by acknowledging the very quick change that happened there, the fact that there was very little consultation, certainly not within the health organization. And so a lot of people felt not only distanced from the new model, they couldn't see themselves in it. I think most importantly, nobody could see where they fit in. And I regularly met staff who were showing me the 6th business card that they'd had in a year because their title and their function had changed. So, I think we have to acknowledge that occurred. I think a lot has improved. A lot has improved since then. I think there's still a ways to go, but the SCNs in particular, the decisions about allocation of hospital resources, you don't want those made by a minister. You don't want them made by an elected person. You want them made by and with the input of professionals. So the SCNs with the researchers, the clinical leads, all of the other disciplines that are involved, I think that's the table where these things should get worked out. I know there's some concern about some of our response to the Health Quality Council report, but I can tell you when our 7 major hospitals are operating at 100 to 110% occupancy for extended periods of time, I absolutely am concerned. I absolutely am concerned. And the point of the exercise wasn't to sort of find fault or point blame or put one clinical lead in competition with another for resources. It was to acknowledge that as an organization, AHS needed to respond to bring those occupancy rates down to a safe level. So I think it's improving. I remember the question that you talked about. I think if I could be so bold as to offer some advice, I think those leads of the strategic clinical networks need to hear from you. They need to hear about what the focus is, but they also need to hear about your experience in terms of being involved with them. And for people that aren't plugged in, who feel they need to be plugged in, that's where I think those issues will be addressed. On your second question, obviously wouldn't be appropriate to talk in detail about the negotiations. What I will say is that it takes all sides to agree, and we had done some very good work prior to the election, and we had worked out exactly what you said, an agreement in principle, and there are changes, and I think still changes that both sides want to work out. Do I think we're getting close? Yes. Am I hopeful? Absolutely. But I also think that we're coming into an age where we need to work. Our physicians need to be at the table. We need to work with them. We need to work with all of those other professions as well, and they have a very major stake in our success in some of the things I talked about. So I think the AMA is very much on side with it, and I realize it's an extended period for doctors, and I've continued, and I've actually increased some of the funding in the interim period. I increased the funding for PCNs, for example. So, but I'm hopeful that we'll get past this soon, because it is, it's there, right? And it would be great to have it resolved and move on. That's the goal.
Mr. Horne, thank you very much for a very thoughtful presentation this morning. As you reflect on the investment in resources that you've discussed, you would know that many in this room are conscious of the fact that half of what we're doing is probably wrong and half of what we're teaching is probably wrong, which leads me to the question as to, of the billions in healthcare that we're expending, do you have a sense of what proportion should be invested in research and development to actually help us strategically think and practice more effectively in the future, as opposed to what we're doing today?
Well, that's an excellent question. And, thinking back to Premier Lougheed, let's not forget, regardless of whether we've got one health region or 10, a big part of our brand in Alberta is excellence in academic medicine and our reputation as a strong academic health sciences center in North America. I don't have a sense, and I don't, my ministry doesn't fund the research directly. I guess when I think about it, and I'm quite happy to be challenged or corrected on it, but we need more research, but we also, I think, need to just simply start doing the things that we know work. And I think, what was a breakthrough that we had recently? There was a new pathway announced for lung cancer surgery, and I think it was the work of the Cancer Strategic Clinical Network. And the way it was explained to me, there was a really solid look at the evidence with respect to, you know, appropriateness of drugs, devices, and procedures, and clinical protocols. And through some agreement, a discussion informed by that evidence, the people involved were able to get to an agreement as to, at this point in time, this is the optimal way to approach, you know, the following services. And so by simply codifying that, and by simply doing what people already know worked, as was demonstrated by the evidence, that initiative was able to save $15 million, which was then able to be reinvested in that same service to fund more services or to fund better services and equipment. I'm not sure exactly what, but the benefit of that applied research and that discussion through the SCN, the benefit was accrued back to the service itself. It didn't go into administration, and it didn't go back to the government's general revenue. It went back as a reinvestment in healthcare. So I think there's some work to be done in terms of the pure research, and Alberta Innovates Health Solutions, and I'm trying to see what I can do with Minister Khan to better coordinate. What do I want to know? I want to know what's our research agenda on cancer as a province, and I want to know how that stacks up against other jurisdictions.
The conference is about to end.
I guess that's a cue. So, yeah, you know, not how is it going to overlap or duplicate, but how is it going to complement on an international scale the other research that's going on. That's the position that I would like us to be in. So I'm sorry, it's probably not a very direct answer, but that's the perspective on how we're trying to attack it.
I think we'll take one more. Thanks for coming out again, Minister Horne. Just wanted to ask you, in your speech, you talked a lot about the opportunity cost of spending on healthcare, and more healthcare doesn't necessarily mean better health. But as health minister, you're sort of always addressing health professionals and investing in healthcare infrastructure as part of your job. So I sort of wanted to ask sort of what the agenda, I guess, for Alberta government is in shifting that opportunity cost, and sort of what it might mean for how. I know you've addressed some of these things in your speech, but sort of more specifically, what's that going to mean for health professionals in the future, and sort of what are the big changes that we expect to see in terms of spending more on non-healthcare priorities in the future?
Yeah, well, very briefly, because I guess we're going to go off the air here, but those are big questions, right? And ideally, the way we would like it is we would be trying to fund outcomes for the future in all those areas by looking at it as an investment as opposed to a cost center. So are we going to continue to support education and advanced education? Absolutely. I mean, I'm not looking to spend more on healthcare other than those areas where we really need to spend. The key is really bending the curve on things like cancer through strategies around primary healthcare. That's how we're focused. The game is to not get to 50%. You know, that's to me, because then the really tough choices and the discussion that we don't want to have, we shouldn't have to have in this country, that would then be on the table. And I don't want to be in the position Ontario and Quebec are in. And I don't think we have to be with your leadership and support. Okay.
Thank you very much, Minister Horne.
Thank you.